Shane is a patient of mine, and he's been a patient throughout the medical system, and he's going to tell a little bit of his story today, so I'm super grateful for him. I believe Dr. Edwards' mom at the conference talked about including the patient, and that was my intent this morning, is that we include the patient in this story and be able to hear his story from his perspective of what worked well and then what could improve, because that's what this group's all about, is improving. So this morning I want to talk about what's called the Deadlift Dilemma. The dilemma meaning what is the benefits and drawbacks to a deadlift. But the message is so much deeper than just a deadlift. It's about how what we say can either positively or negatively impact the patient's story. So as we go throughout this, I hope you can think about, what are things that we do on a regular basis that can deter someone's story and what their end goals are. So what are things that you've heard about the danger and benefits of deadlifts? I'm going to start with the discussion. Go ahead.
Great strength developer.
Love it.
I was just going to say posterior strength. I mean, one of the necessities is just that posterior side being on the pole.
All right, raise the hands. Who's non-clinical in the room? So we have an idea. Everyone know the term posterior? Posterior is the backside. Good strengthening for the backside of the body. So anything glutes, hamstrings, low back. Thanks, Jake. Any others?
It's the movement where you can add the most weight for most people. It's their heaviest lift.
Yeah.
So they get the most exposure to resistance for strength training.
Why is it the heaviest lift? Typically.
Typically because the mechanics of it, it's where your body's super strong. You're using your back and both legs to move the weight. So
Yeah, it's kind of full body movement.
full body, yeah.
Love it. Any others? What are the things, we want to hear, what are the dangerous things you've heard about it? I know we've all heard them. Go ahead, Dr.
You don't know what you're doing, you can really get hurt.
So it can be a very dangerous exercise.
It's easy for people to have bad form, which therefore can lead to injury.
Yeah, we'll talk about bad form, what bad form means, but absolutely.
Done incorrectly, it's great for business.
Keeps the ball rolling. There's some truth to that for sure. Absolutely. Okay, there's a lot of truth to that. Go ahead.
There's a lot of intrathoracic and intra-abdominal pressure created during the lift, so you can activate the Valsalva reflex, and some people will put the weight down and top hawk right into the floor.
Yeah.
Lose consciousness.
Absolutely. Has anyone ever seen a soda can, one soda can that has 1,000 soda cans stacked on it? Anyone seen that? Raise a hand. Pictures of that. You can literally create thousands of pounds of pressure on one can when it's pressurized. But when that can is open, what happens? You can literally collapse it, right? So if people can't control the intra-abdominal pressure under a huge load, what can happen to their spine? We got to teach them how to brace that. Go ahead.
From an engineering perspective, as you move that moment arm forward, it really increases the Newton force, the compressive force of the disc exponentially, which can be dangerous.
Absolutely. And if you think about the biomechanics of the femur, the longer the femur, so say I have someone like me with short femurs, and then we have someone with really long femurs. The longer the femur, the more the hips are back, the more you have to lean forward, right? So the more torque that can be put on different areas of the body. So mechanics of the individual person we have to take that in consideration as well. So a deadlift for someone with short femurs is going to be a lot easier than someone with long femurs. So biomechanics is huge. So is deadlifting good or bad for your back? Should everyone be able to perform a deadlift? What does the literature say? What are our biases? What are our biases? Do we say in our minds, is it a good thing to be doing deadlifts? Is it a good thing to be moving in that way, right? So does everyone deadlift? This is the help of AI. But let's answer that question. Does everyone deadlift?
Yeah, to some extent.
To some extent?
Yeah.
Tell me more.
I mean, you're looking at a lot of functional activities. If you need to pick something up from the ground, you're almost doing a deadlift.
Yeah.
I mean, if you do it improperly, then it's the same as the other activity. But the same rules apply. Tighten your core, keep the weight close to your feet, drive through your hips. If you can teach those aspects, then you can keep people safe. But people lift inappropriately all the time.
So back to Dr. Bowden's statement, you have to know the technique. So should everyone, based on these pictures, you have grandma lifting a laundry basket here in a deadlift position. You have a toddler picking up toys. You have maybe a dad or a guy picking up a couch. And then you have a power lifter deadlifting a barbell. And then you have a mom picking up a child. They're all a deadlift technique. So should everyone know the mechanics of a deadlift? I think we're all in agreement that everyone should know them, right? And be able to perfect them and be able to understand how intra-abdominal pressure relates and can be connected to the item that you're lifting off the ground. So I want to start out with this MRI. So who is non-clinical again? Yeah, that's what I'm talking about. I'm going to pick on you. Tell me what you see in this MRI. This is an MRI for everyone that's a non-clinical. We have the nice arrow sign, you know, an arrow. We all know what an arrow means.
I do see
What do you see?
an arrow right in the middle of the picture.
For sure.
To sort of
A big arrow.
Black area.
Yeah, black area. What's this black area? What do you think that is?
A disc?
Yeah. So even non-clinical, you can look at that and say, there's something wrong there. All right, someone jump in clinical. What do you see?
Please say the arrow.
Besides the arrow.
Looks like a herniated disc at L4-5 and some maybe protrusion at L5 as well.
Okay, what's the method of treatment? I want to hear from everyone. PTs, MDs, surgeons. What's your method of treatment? If you only saw this, you don't get any of the exam yet. That's a pretty good one, right? We can all agree. It's a pretty big one. I mean, you can see the spinal cord's actually almost completely compressed, right? There's no space where that spinal cord is. So what's our method of treatment? Call John. Like it? What else? So John's a surgeon, if anyone doesn't know that. Go ahead.
We have a spinal decompression.
So this person comes into your clinic, spinal decompression. Great.
I got to go back to this doesn't tell me anything other than you have an MRI.
Thank you. It's huge.
Honestly, right? So what?
And I think that's why everyone's nervous to say anything. They're like, oh, I don't really know the exam, right?
I don't know what the symptoms are. Slightly less than that, you could be 75% of the population running around with a disc bulge.
Yeah.
Slightly more than that, you could have a lot of pain and a lot of weakness. So I guess it just depends on what's going on. So
What would typically be the neurological presentation of this condition? If you were only to see the MRI, what would you think the patient would have neurologically?
So again, without knowing the symptoms, it's really hard to say because you can take many people off the street who have no symptoms and put in the scanner and find these kind of things. Yeah.
Is it that large,
I
typically?
think this is probably larger than most, but
Yeah.
most people will have an abnormality.
Yeah. Tyler?
So when we're talking about disc herniations in the lower part of the lumbar spine, the first thing is reassurance to the patient because they often make that comment, well, my spinal cord's compressed. Well, actually, your spinal cord terminates up higher. So we're talking about the spinal nerve roots, which is like a spaghetti that was breaking down the sac, is what I tell them. There's a little bit more resilience because of that. At L4-5, when you have a disc herniation there, you're looking for neurological deficits like foot drop. Numbness we don't get too excited about. Incapacitating pain, debilitating pain. That's something we're going to think about, moving up the chain of command as far as treatment. But we always offer reassurance. I mean, I've seen large disc herniations reabsorb over time. I hate to use the word heal. I don't think that's the right statement, but definitely get better. And
Yeah.
So a lot of reassurance early on, unless there's obvious motor dysfunction, and then you're obviously making a decision then to move a little bit quicker in the treatment algorithm.
And motor dysfunction would be the legs stop working, right? It could be a foot drop, it could be a leg weakness, an inability to move the leg. You could have radicular symptoms, pain going down the leg, sharp all the way down to the foot. There's all different things. You test the deep tendon reflex, it could be diminished. Sensation could be diminished. Those are all the things that we're looking for. So the beauty is we have the patient here. So we get to have him tell us his story. So he'll introduce himself, tell a little bit about his background, and then tell about his presentation, and then also what went well in his process and what could have gone better.
Okay. So, okay, Shane Waller, nice to meet you all. 5 years ago, 2019, I was 5 days out, 7 days out from surgery. Rewind back probably to my teenage years. My mom had surgery like once or twice a year, it felt like. Like she was always, I don't know the frequency, but I felt like she was always recovering from a surgery. And so growing up, I was like, I had a bad back. Because every time my back would hurt, I would just think of my mom, I had a bad back. So then growing up, I get married, I start family, I start a business, go to the gym every single morning, and injured my back picking up. It actually wasn't even a full laundry basket, it was just a t-shirt from the ground. And I got up at 4 a.m. 5 a.m. rolls around, I'm still in the bathroom. My wife comes in, finds me butt naked on the floor, unable to move, and starts laughing at me. And you can know my wife as well. Starts laughing at me, wondering what I'm doing. Okay, so I physically couldn't move. Everything that was going through my head, though, she's like worried about my back, right? Like what's going on there. Things I'm worried about was I'm gonna have to shut down my business. The only income is me. Like, how am I gonna take care of my employees, my family? I had 2 little boys at the time, were 4 and 2 years old. Right? So like all these things were going through my mind. I was just scared out of my mind to move because I didn't want to permanently disable myself. So 6 a.m. rolls around, both my dad and my father-in-law come over, physically lift me up and put me in the bed because I've been on the floor for a couple hours. EMTs come, they were going to take me to the hospital. They kind of pick me up and physically carry me into the car, move me to, I guess I went to the ER. I don't know, it's like all still blurry. Like I don't remember most of it. But I went to the ER, had an x-ray, and I was pushing for an MRI because I knew I'm like, there's more going on. X-ray, they're like, yeah, nothing is wrong. It's a muscle spasm. They prescribed me some muscle relaxers. They prescribed me some, I guess, just PT. Then I go see the PT. Sent home, came back to the physical therapist at the hospital. But I saw a different physical therapist every time. They didn't really know what was going on, who I was, what I was dealing with. They gave me this exercise, and I just went home. Not to bash on them, but my perspective of that at the time was, I don't need physical therapy. I need a surgery because there's something actually wrong physically in here that cannot be fixed. That was my perspective at the time. Finally, I did get another injection. I think I got 2 injections. Neither of them really helped. Finally, I went and I saw 2 surgeons. Both told me, based on the MRI and based on what I was telling them, only options were surgery. Since I had already done PT, the only options were surgery and microdystectomy. So I had that scheduled, went to the pre-op appointment. The doctor that I was going to use told me never to deadlift again, and I think he said chances of re-herniation is like 90% after the surgery. You guys all probably know the stat like that. But whatever it was super high. And so from there, I was like, well, that doesn't, like, basically I'm going to re-injure my back. That's what I heard at that point. I love going to the gym, I love working out, so I can't do that either. So there's just like this really big lull of depression for me. Looking at all, like everything I thought I had done, like I tried physical therapy. Talking with Brad one day, he and I are good friends. He doesn't remember this, but he kind of yelled at me and told me not to go get the surgery without coming to see him. So Brad told me not to brag about him, but bragging about Brad, the confidence that he had, like, hey, come in and see me, let's figure this out. I don't know if he needs surgery or not, but let's just give it a try. Walking in and seeing him and his confidence and knowing, like, hey, he actually cares and will put in the effort. I did cancel the surgery, expecting to just be in pain for a couple more months and then to have the surgery again. But I was just very, very committed, knowing his commitment to it. Very, very
Tell us about the symptoms you felt in your legs. It's kind of your overall, like what you looked like. How your legs functioned, how the symptoms were in your leg.
Horrible. Like I couldn't do anything. It was my left leg, the pain in my shin. It was just like needles nonstop. I was working from bed 100% of the time because I couldn't sit in a chair. When I would go see, the only time I would drive was to go to physical therapy. And when I would do that, I would drive like 5 miles and then pull over and like lean my chair all the way back, take a break, and then lean it back up again and like drive a couple more miles as much as I can handle. But yeah, I couldn't, I was just like limping basically when you first saw me come into the office. Yeah, no strength at all. Like couldn't do anything. I'd use a walker to get to my toilet. Was I shared with my bedroom, and even at that I wouldn't like fall when I was peeing.
Thank you.
Yeah.
Perfect.
Yeah.
What questions do you have for Shane? We're going to keep talking about his story as we go, and you can fire questions at him. Any questions right now? The symptoms presentation was pretty intense. So his deep tendon reflex was almost gone, which is like one of the positive predictors that surgery is appropriate, right? His myotome, when you test his muscles, they were like 25% of what the other side was. So he lost a ton of strength. And really what came down to is we said, let's keep the surgery on the schedule, let's work on it, and if we have improvements and we are uptrending, then we'll make a decision at that point. It wasn't a hard conversation like surgery is not appropriate. It was more, let's just keep it on the schedule, and if we're making improvements, then we'll continue. If not, then we'll jump into that surgery, because we all know the ramifications if we keep letting those weaknesses happen, right? If there is compression on those areas, it can cause some significant long-term effects. So we don't want that. So is the education that we're giving building resilience or fear? Who's heard some of these things? Raise the hands. Which ones have you heard? Go ahead. Share the ones you've heard. Or there could be more too.
Probably all of them.
Is there one that sticks out for your profession more than another?
I mean, as a physical therapist, definitely the donor to deadlift again, those top two, this is the worst back I've ever seen. Yeah.
At PTs in the room, how many times have you heard a patient say, my surgeon told me that this is the worst back they've ever seen? Raise the hands. We hear it all the time, man. If I had $1 for every time, how about knees? Like, that was the worst knee I've ever seen. You probably said that 300 times by now, right? It's really not. And the thing is, do patients just perceive that you said that, or did you actually say it, right? I think all of us in this room know Tyler really well. I know Tyler really well. A patient comes in the other day and a patient said, Tyler told me that surgery was the only option, that this disc would never heal. Raise your hands, who think Tyler would say that? Absolutely not. We all know Tyler better than that. But I have to have patience for Tyler because I know for a fact he didn't say that, right? But the patient perceived it in that way. So is what we're doing, the way we're educating, is it instilling in our world resilience or fear? That's really what we got to get down to. The way that we speak, is it changing people's story in a negatively or positive way? Any other thoughts about this?
I love that story about Tyler. I think.
Sorry, Tyler. I
think the thing that we have to remember, not only is there a limited number of things a patient's really going to hear, but they're going to come into the visit with you, whoever that is in this room, with a preconceived notion of what needs to happen. They're bringing that lens, and that filter, that's probably better as a filter, they're bringing that filter into the appointment. And that filter is informed by whether your mom had a bunch of surgeries and your whole family, I have bad hips in my family. Okay, thanks for that, right? And they're like, and I heard the doctor say something. Tyler said, you're probably not going to need surgery, and you left. It's like, he said surgery.
Yep. Exactly.
Right? And so we have to remember that we're bringing this bias from your neighbors and your buddy down the street and your 7 friends who had back surgery or microdiscectomies or meniscectomies or whatever. You're bringing all those things in. It's, oh yeah, I tried PT, it didn't work. So you're bringing all those things into this visit with you. And so we have to be really, really careful about what we say. And I always ask, like, so do you have any more questions for me? Do you understand what we're talking about? And on these points, we call them these little tipping points, I'm very clear. Like, I'm not saying you need to have surgery. And I'll just look at them and I'll pause there. I'm not saying you don't need surgery. I'm saying we're gonna figure it out. And if you do, I'm not saying you do, and I'll continue to back that, back and forth, so that people don't leave and say, oh, my therapist said PT's not gonna work, I need surgery. Because early in my career, I'm sure it happened.
Yeah. I'm curious of the physical therapist in the room. We had Shane tell a story about how PT wasn't helpful in the beginning. He felt like he was maybe tossed around to different therapists. The story wasn't consistent. What can we do so go ahead,
The
Shane.
diagnosis at that point was muscle spasm, officially, right? So they were treating muscle spasms.
So can I ask you?
Go ahead, Ron.
your MRI?
Sorry.
Did you get the MRI before you did?
I
You
did.
said you went to the ER.
I did that first round. Well, I did ER, X-ray, PT, injection, MRI, second round.
What was your feeling about getting the timing of all that, the sequence of events? Did you feel like you needed the MRI early?
I thought I did. I thought I needed to know what was going on. Also because of, to your comment, my mom having bad back, and I needed back surgery.
Right.
So it's like, we need an MRI so that I can get back surgery.
So how did you feel not having the MRI when you're doing all these other things? Do you think these guys are just not really understanding the problem, or?
Oh yeah, absolutely.
And I think it really highlights the importance of knowing that we diagnose and then we treat, right? We don't just do what the referring provider said, it was a muscle spasm. We have to be doctors of physical therapy and diagnose the right issue, right? So as far as story time goes, I had my daughter come to me one day, and she told me about her friend that was doing the monkey bars, and she tore her hands on the monkey bars, right? And she said, I don't tear my hands because I've been consistently working on the monkey bars all year. And I said, let me see your hands. And she held them up like this, and she showed me all of her calluses, right? The human body naturally changes as we appropriately load it over time, right? Back pain is just a musculoskeletal condition that we all experience. It's not a medical condition. It's not cancer. We can't treat it as such, right? And it's so important that we understand the appropriate load over time. Disc herniations, 85 to 90% of them naturally heal in 6 to 12 weeks without any substantial medical intervention, right? Another myth, lifting heavy weights is bad for your back. Exercise programs, including deadlifts, are clinically effective for the treatment of low back pain for both pain scores and functional outcomes, right? So what athletes have the strongest spines? Weightlifters, powerlifters, gymnasts, rugby, football players, martial arts, and wrestlers, right? They have the strongest resilient spines. Why? Because they appropriately load them over time. It's very, very important in the research. So of these sports, why do they have stronger spines? Why do they get injured? Here are the deadlift faults, things that we look for in deadlifts. Here are the key techniques. We're not going to go over them today for time's sake, but there's certain techniques that we look for. And I'm going to skip his video, but this is Shane deadlifting. Was it 225? Pretty impressive. And then we're going to end with this. How can we build resilient humans? How can what we say impact other people's story? They're all unique stories. We all bring in our biases. We all bring in the impact of our lives. And we have an opportunity to speak to these patients. Shane, he felt deep depression during this, where he felt of this heavy weight of how he was going to provide for his family. Right? He went to these different places, and they either gave him hope or they gave him despair. Which is the message that we present to our patients? Are we presenting hope? Are we presenting resilience? Are we showing how resilient humans we are in society? So thank you for coming today. Appreciate your time.